ONtheGO podcast.
We are live at ESCA 2024 in Milan with the research architect Giuseppe Filardo, professor at the Faculty of Biomedical Sciences at the Università della Svizzera Italiana, and head of clinical research of the Service of Orthopedics and Traumatology at the Ente Ospedaliero Cantonale in Lugano, Switzerland. Having a coffee break with Dr. Jari Dahmen, Amsterdam University Medical Centers, University of Amsterdam. My name is Taka Oshima, and this is On The Go, the podcast all around orthoregeneration.
I'm happy to be sitting here with you, Giuseppe Filardo, and to have you on the podcast. Welcome.
Thank you so much.
And we always ask our guests as a first question, because obviously we're in Italy and you're Italian. How do you like your coffee? How do you drink it?
So this is supposed to be a question to make me comfortable, but it's a really tough question because we are in Milan. And I don't drink coffee.
Nothing.
So they could take away my citizenship if I don't know about it. And I'm weird in this sense. I don't drink coffee, but I really enjoy a good cappuccino.
Good cappuccino. And not after 11 a.m. then, I guess.
Yeah, that's they look bad at you if you ask afterwards. No, usually in the morning. Yeah.
And so when you go to work, is there a safe space for you that you go somewhere to just go away from all the hectics of the work to drink your cappuccino, or you drink it with colleagues?
Actually, I like it in two ways. When I work remotely, I have a little cafeteria down the corner. In Italy, you have these family little places, and there is an old Sicilian man that has magic hands. He does an amazing cappuccino, and I like to start the day with my wife.
Yeah.
When I'm at work, the cappuccino moment, the coffee moment is actually a really important work moment because you never go alone.
Mm-hmm.
You go with people, you go to meet people. And actually, just by being there, you can meet people that are just passing by. The cafeteria is like the heart of the place, right? So, and it's a good way to create connection, to know what's happening, and also with your team to talk about something that maybe you wouldn't discuss when you're just down on your computer. So, I think it's an extremely important part of the work, and it happens more times. It can be 1 at 7, 1 at 9, 1 at 11, when there is someone and we need to take a break. And it's relatively a break, though. It's a really important moment, I believe.
So it's the way of also socializing for you and your team to bond together and have everyone together on the
Sometimes I'm with the lab guys and I take a break, I go to the coffee place, but there I see the doctors coming from their clinics and we can discuss and update. And it's a really great moment to align.
Yeah, there's some spontaneous meeting there to align.
And truly, I think it's also, I don't know, maybe it favors different attitude, but more openness, more to new ideas, to more work to carry. If you do a meeting in a cold room, it's like... if you're there and more relaxed, sometimes it helps that as well.
To think of new ideas and to get onto new ideas.
With a more comfortable.
Just like we're sitting here as well. Yeah. That's good. So also part of our podcast is going to the future, going to 2040. And of course, you're the, as I would like to call it, the professor of PRP. Can you tell us and the listeners a little bit about what PRP is, what it is used for, around the world nowadays, and then later on we will try to go to 2040.
Okay. Well, I have to make a kind of a summary because I just gave a half an hour keynote lecture on this indication. We cannot repeat it, but it's difficult in every stage. Even the definition is not shared. What I can say is a concentration of platelets. More than the blood level, but then some places, some countries accept 2-3 times more. In my country, for example, they want it to be at least 1 million, which usually corresponds to 4 to 5 times more. So it depends on the country. I also believe I'm not really strict about it because it's a fake problem. It's not just a matter of concentration, it's a matter of concentration and amount of ml you put. So in the end, the final dose you're going to give, that's the main thing. So it's not just how much your device can concentrate. It's a more complex issue. But yeah, the overall average definition is a concentrate of platelets. Some products, they claim they are PRPs, but they barely, they are kind of blood without red blood cells, so that they aren't real PRP. But marketing-wise, sometimes gets confusing.
So I hear there's also a lot of room for improvement with regards to talking about it in the same way, definition of PRP across the globe, maybe across within Italy as well.
Yeah, that's something that seems easy to reach, and many experts try to do classifications. There are many used, and maybe too many, because then, if you have to take a common language and everybody classifies in a different way, in the end you don't allow for clarity. I think also in that case, is useful, is important to document what you're injecting, but I like to check. I'm a clinical scientist, so we try to take 200 cases where we had everything dosed, and we applied classification that's really used in the field. And then with the same device, we obtained 4 different kinds of PRP, because it's a biological product. And if I start with 450,000 platelets and you with 150,000, you know that it's going to have a different amount of platelets in the end. It depends on the size of the platelets, and these are all factors we are not accounting for those. So even the classification is more like a wishful direction. Some things you can classify, because you can say there are leukocytes, there are not, but then when you have them, how many, and how did you treat them, because they can be good in secreting some factors, they can be not good. So I know I don't give straight answers, but when you work in this field since 20 years, you realize that it's really layered, and you can have a really easy answer, and this is PRP with or without, or
But the actual answer is way deeper on very many levels.
And
you're trying to get to all those levels in your research.
You have to consider all of them, at least trying, because then results may be biased. We had 10 years of the field focusing so much on leukocytes, and that was not it, at least in the osteoarthritis environment. We finally managed to do, after some early trials, double-blind RCTs, actually 2, one with frozen PRP, but then people say we use it fresh, then we did fresh, 200 patients all the time, double-blind, and it didn't really make a difference, And so this was a myth that actually showed it was not true, and it took so long to, they showed some in vitro studies, and they showed that leukocytes are killing the cells, and suddenly people say, whoa, it's so detrimental, But one thing is you have cells naked on a plate, and another thing you have cells on a matrix, well protected. And so what we saw, for example, is that if you have leukocytes and you put it intraarticularly, you may have maybe 2-3 days of a bit more swelling and pain at the beginning, but all the rest of the response to it is basically overlapping with or without leukocytes. And actually, what counts the most is probably that's what we are seeing in the latest study, is the amount of platelets you put, which is correlated to the concentration. And the point is that most of the times with the devices you can buy, when you don't use filters, and we often use laboratory-made PRP in our hospital, but when you use devices, you want to have more platelets, you bring with you the leukocytes, and this is a really confounding factors, because is it working better because it's a concentrated PRP, or because it has more leukocytes, or despite it has more leukocytes? So you see how they interact things in a complicated way.
Many levels, and sometimes it's difficult to really shift them only on one level, and then you don't know what the effect is of the other level that's going in there. So many unanswered questions, I think.
Scientifically, the challenging part is to isolate the variable you want to study, right? So we had to find ways. And for example, for studying the presence of leukocytes or not, and we looked at the market, and we had devices that gave you with or without leukocytes, but with different amount of platelets. So, you have 2 variables suddenly, presence of leukocyte or not, and number of platelets. So we had to find a way. And we found 2 in the end, and to have the same number of platelets with or without leukocytes. But if you don't overcome that problem of isolating the variable you're studying, you're never going to be certain that the results are really solid to answer to your question.
And now we're even talking about differences amongst the group. But we also heard in your highlight lecture today, or your keynote lecture, that you used yourself as a subject and saw that within one person there's also differences. How does that affect the research?
It is a fun provocation I like to do sometimes. When I started 20 years ago, first of all, we were talking about regeneration, not about homeostasis. There was this hype about PRP. And, growth factors, you think growth factors, maybe they can regenerate. And so in the earlier study, we won a few grants, and we tried to go and check the amount of every growth factor. And that's something that after a few years, there's still people doing and wasting money. But the more you look into that, the more you realize it's an uncontrollable cocktail of hundreds of molecules, someone you've never heard, okay? And you talk to other biologists, and they say, why don't we check this? And then you check it, and it seems to influence things as well. So I did that provocation by taking, I did so many experiments, and I'm the perfect candidate because I'm always available to myself. So I took my own blood on different occasions, and I dosed it. And the growth factors were changing based on the day, based on the hour, based on the arm. The natural variability is huge. That's why I think we should keep it in our mind as a biological product that has variability, and we should not look for the dream moment where we're going to really control it, because at that point, let's just use growth factors and bioactive molecules as drugs with the perfect dosage and so on. But there's another treatment. If you want this off the shelf, ready to use autologous treatment, then you should give up to control everything and just try to understand major trends and be happy with that. It's also a matter of costs, and maybe you cannot control everything, but it's relatively cheap. And maybe if you arrive to control everything, and we investigated ways to do it, to clean, filter some molecules you don't want based on the indication, which is really fashionable to say, but if it becomes so expensive at that point, maybe we are starting with a wrong approach. Let's just go to drugs and pharmacology.
I think that also gives us a good bridge to 2040 or even later on, when this orthopedic medicine will be more personalized, because you say like so many variables affect the maybe not even the outcomes, but at least the concentrations and leukocyte poor, leukocyte rich, all those effects that it has. How do you think we will be able to individualize, for example, PRP treatment in 20 years? We will make a personalized cocktail for example, if you have a problem with your knee, then you take some blood samples beforehand or some stool samples beforehand to find out what works best for you, instead of treating it on a group level.
I know that's something that is desirable. Many people believe in that. I'm not sure that commercially speaking, and you always have to think commercially speaking when you want to reach the patient. One thing is academy, and one thing, and commercially speaking, you have also to make it sustainable financially. The technology cannot really be too complicated for that, for a massive use. I'm not sure we're really gonna get there. And I'm not even sure that's a real direction. For example, when at the beginning we started studying in vitro PRP, we compared the results of PRP with the results of specific growth factors that were used in molecules, right? And you could control the dose of this molecule you put in culture and see those response and all these things. But what was striking is that one molecule often was not as effective, even though you controlled it so well, while the mixed thing that you don't control was working similarly, cheaper, and so on. So I think I'm not sure that is the way to go. We were going to improve something. We are going to maybe control some major aspect. There are already some devices that can control to some readers if the leukocytes are coming, and so you can stop it. And major things is going to be the case. But in 20 years, I think the big work is going to be done on the other side. not on the treatment, but on the identification of the patients.
Okay.
And I think most of what we are missing is not cooler treatments, but a better understanding of the pathology.
Yeah, the profiling.
I make sometimes fun of us and of the field, and I say that we treat neitis.
Yeah.
People that study these things better than me are trying to identify phenotypes of osteoarthritis. Yeah. And I think they're going to have to improve there, even though it's not so easy, because I can read some experts that say there are 4 phenotypes, there are 6 phenotypes. And the point is that you can be a 50-year-old man with a previous meniscectomy, microtraumatic, but also be overweight and have some metabolic and maybe some genetic. And so how do you define that phenotype? It's not going to be easy, but I think that's going to be the key, because once you identify your phenotype, maybe if it's more a matter of an anti-inflammatory action, you're looking into your PRP or something else. So I think research to change the field and change the results in 20 years is going to be more on that side, or at least it's going to be more impactful on that side.
Well, that's actually interesting that you mentioned that, because that's also very much in line with what Professor Philip Niemeyer mentioned on Wednesday in our podcast. It will be out soon. You haven't had the chance to listen to it yet because we're still processing it. But he was also mentioning that patient profiling will be the future. And regarding that, I always like to ask the question, and the idea I stole from my colleague, so I have to give the credits to him. But if you would be given 20 million euros to do research, for example, on patient profiling, to have some questions answered in 2040, what studies would you do to pick your brain?
Different one. I mean, only 20 million?
20 million.
Only?
Yeah.
Well, that's not a lot.
Or 40 or whatever.
kidding. Through my career trajectory, I try to look at problems from different perspectives and collaborate. I'm in a position where I can collaborate with really different expertise and professionals. I think you have to bring together a diverse group of expertise, and often we have orthopedic surgeons, sometimes collaborating with biologists, but where are the immunologists, sometimes with radiologists, where are the neurologists, where are the psychologists? Because, for example, we did a study looking about the component of the neural component of the pain, they call it nociplastic, neuropathic, even though it's not a correct way, but that's most of the time to call it. And there one every 4 patients, and I'm simplifying, of course, but is affected by that kind of central pain. So you treat locally the problem while you forget that. So that's an example. And then psychologically, we have a mental elaboration of the pain experience. Some people are working on that, but they're working on that separately. Each one is working separately on the problem. So if I had a lot of money, I would like to put people together to make a bigger study, but not many small studies trying to focus on one problem because they are expert in one problem and then missing all the rest. And in the end, they don't understand because they couldn't control the other things that they didn't know. So I think I would bring a big team together. I'm not trying to tackle alone the problem.
No. So one diagnosis, and then you would like to make some patient groups, for example, or patient profiling based on the multidisciplinary approach. Is that correct?
And that's the first step. And once you identify subgroups that show a different, potentially different behavior, different response, then you organize randomized controlled trial on targeted groups.
So you specific subgroup.
Yeah, because you reduce the variability, which statistically is what sometimes prevents to see differences. And so by going to specific groups, you may be seeing something more, and which group is more responsive or not. It's not going to be really a profile like, an ID card, you are going to respond. But you get closer, you belong to a certain group that is more likely to respond to this or not.
Well, that's something that you'll probably already be working on, as I can hear from you, how concrete the ideas are. Any other innovative
I'm
ideas?
missing the 20 million for now. The rest
we can organize it with the On Foundation afterwards. Any other innovative ideas that you have regarding like patient profiling or individualizing treatment? Because it's very interesting to hear that from you.
More than that, I think I like to talk about the innovation of how you do research, which is my main love right now in my career, and how you create a system where you create expertises that are needed to tackle the problem together, training the young generation with this perspective. And I come from surgery, and I can talk to surgeons, and I understand them. On the other hand, I can see the limits of it. And so I think if my main effort wants to be, if I want to accomplish something, I believe in the future, is to surround myself with collaborators that are trained and used to work together, but with different expertises. And so is the creation of a new generation that has more perspective inside. That's maybe the area where I like to work the most right now.
I think it also gives us a good bridge to the second part of our podcast, picking your brain and asking you how your trajectory was going from a doctor to orthopedic surgeon and orthopedic surgeon scientist combined function to now full-time scientist. Could you tell us a little bit about us about how it went?
I love to. You have to stop me, actually. Well, I started as a resident and briefly I was an orthopedic surgeon, then I was a researcher, and then more a manager. And right now I like to call myself an architect, because what I observing how things happen, I realized that even really the good people, the one that changed the field, the visionary ones, they have time to do research almost like a hobby, because they have so many other things, responsibilities, and so they are working really hard, almost alone, with a few people. And once these people are mature, they go away and become lonely runners as well, you know. And I saw this, and well, it took some years, but right now the position I fit in the system where I work is close to the scientific direction. And, you know, the scientific direction gives you the where the institution wants to go. You know, it's really important strategically, because if they want to invest in a direction, it's good that you align with that. You cannot fight your own institution, right? You have to understand where they want to go and see if you're aligned. And then if you're aligned, they need to know how, but the how, only the people working in the field know it. So you need a chain that connects these two and has the vision, the lateral vision, not just the specific vision, the vertical vision. And so when you put this position, this is an architectural position, you can kind of take from the different groups the specific talents that are needed for specific project. I don't mean to destroy all silos. Silos is a really good way, simple way to organize a group, because by doing silos, you give responsibility to people. You have one boss, people have to, you know, refer to the boss. And it's really easy hierarchical way to control things. And you know what is your trajectory to go up, which unfortunately most of the time is to create another silos. But then what happens is most of the time, and I see it everywhere, you have small groups, because as soon as someone becomes good, creates a smaller group, you know, and another one. You have these small groups, each one, instead of competing externally in the field, in the world, and each one weaker than it could be, they also compete internally
to go up,
to fight for resources. And this is really energy consuming and benefits only single career trajectories. But if you think about it from the perspective of the institution, they are not really accomplishing the full potential of all the people inside. So I don't say to do this for everything, but what I did and what I do in my work for specific projects that are strategic, I work outside of the silos and I go taking things in the silos and putting them together based on the need of the project. I need this person, I need this specific expertise, and we put them together. And together, you can do something bigger than a single silos, faster, and science is fast. You need to be fast. More efficiently, for sure, better. And that's another positive side. If you have a talent in a little silos, the talent sees his boss as a cup to grow, right? And you're only exposed to the opportunities that your boss provides. But if this talent is exposed to the opportunities that the boss provides, but also to some bigger project where he can really use his talent more, you know, he has more accomplishments, more satisfaction, less need to go away. So you expose him more, you help the talent grow, and you help talent retention because he's happier and has more opportunities. And in the end, the silos is stronger and the entire group is stronger. So it's a really not easy to say, but feasible way, because I proved it. I worked in 2 systems in this way already, and I can prove it in 2 countries. So is a way that makes you work better. People may be resistant at the beginning because you tend to defend your little, silos. But when you realize that by working in this way, the overall productivity works more, but not only in terms of quantity, also in quality, and you have more opportunities, and in the end, everybody gains from it. Then the resistance goes away, and it becomes fun.
Is it difficult to really get into that system and stay to the people involved and try to explain it to them? Do they understand it, or did you also receive so much resistance that you were blocked out of it?
Yeah. Well, to work in this way, and by the way, is something that in the industrial work it happens, because for strategic projects, that's what they do. Okay, so it's not something I'm inventing, basically.
No.
And just
you're applying it.
I'm applying it, adapting it. When I do science, it's cross fertilization. And most of the knowledge of the innovation comes at the border of fields when you import, and cross fertilize. And also the organization innovation comes by cross fertilizing it. Okay, so you have 3 ways to implement this, and it's either as a research architect, if you have power, but most of the time you don't want power, you don't want to compete with power with them, it becomes a bad dynamic. Or money, if the general director gives the money all to you and then they follow you because you have the money. Or credibility, because if you are the super expert on PRP and you go to the clinic and say, do you want to be part of my study, most of the time they tell you yes. So in my experience, I had to work through this balance. And realize that sometimes some people just don't want, and don't fight them. Just work with the one that want. And at a certain point, the resistant one are gonna realize they are remaining behind. And they're gonna
because
try
they see the success and they see the achievements.
And so slowly, it takes years, but even less than I expected, I have to say. The balance shifts, the mentality shifts, and you can change for the better the way an entire system works.
And people came back to you saying, oh, I didn't realize it in the beginning, but now I realized it. And
they don't say it officially, but they suddenly become more favorable for collaborations.
And then you're like, you see, you should have realized it maybe a bit earlier.
It's really rare that you have people really closed for a long time. Sometimes it takes more time, less time, and you don't have to force people. They're gonna come.
And so don't you get overwhelmed now when you are applying this this way of thinking to different systems, to different, I think, institutions, and they see the success? Of course, you're the architect in that sense. Are you not overwhelmed with too many projects that you have to build, literally?
Yes, definitely sometimes, but truly the role of the architect is to understand how the resources are distributed better. Then I'm not only an architect, also a researcher, a clinician. So in my own niche, I am also the leader scientifically. And so I work at 2 levels. I also keep pushing my own field and PRP and orthobiologics, but I help other people to become better than me. And I organize studies that are not my expertise because I don't want to be the expert of everything. And this is what helps you to not to be overwhelmed. I need to help you or another guy to become a better expert, and we discuss together and I help him grow. So the more he grows, the less overwhelmed I am because he can take care. So I provide a system where he can grow faster and relieve me from extra work. And this at the beginning is of course more difficult and more frustrating because it takes some time. But the more you work in it, the easier it actually gets, even though you have more projects, but you have more people able to follow them.
So it's like a clan following this way of thinking, this philosophy.
I will call it a movement of people.
Maybe clan is a bit
and it's extremely fun to work with because once you enter in this system, it's really a collaborative approach, and so it becomes also kind of a friendship too, because you help each other. I know that to have my project done, I need your help. and vice versa.
Yeah.
So it becomes suddenly open.
Yeah.
And when people open, then they have a closer relationship.
Yeah.
And I think it's fun even to go to work, I would say,
Yeah.
in terms of environment, not just in terms of professional
Yeah.
achievement. That's what happened in both places. So
And I think that brings us perfectly back to the beginning of our podcast with meeting your colleagues for a coffee in the morning and to discuss this. So I think we're slowly heading towards the end of our podcast, and we always ask our guests some questions that they don't expect. Maybe you've secretly read some of them already, but what is something that most people don't know about you?
I always run. I'm always giving probably the impression that I have no time and that things are fast and maybe that I don't listen. I think that something that maybe they don't realize is that I actually listen a lot.
Yeah.
And I'm eager to listen to everybody, even when I think they are wrong. I always ask myself, maybe they are wrong, but where is it coming from, what you're saying? Am I missing something?
Yeah.
And I strongly believe that each one has a different perspective, and I can only see in one direction. And I always question if they're seeing something I'm not seeing. So any person, expert or not, I really try to absorb, even when I look busy and running. And I think this is something maybe people don't realize.
Yeah. That's a good one, because obviously we see that you're literally running around a lot and doing so much work. But no, I think people realize that you're listening well to them. Then I guess we always ask our guests also if they have some tips, but you gave already so many tips in this podcast, and maybe following the movement that you introduced is one of them.
I would like to, if I have to give a tip to young people, they have to find something they like. At the beginning, you do more things because you have to have exposure to understand what you like.
Yeah.
Okay. So do not start already convinced. You have to have exposure. Yeah. Then you really understand if you like it, because you had different experiences. After, you have to push yourself through the first phase. It's like when you do sport. If you start running and you're not good and you run the first 3 times, it's painful and you give up. But if you push through it and you become good, then it can become addictive and you maybe even have the runner high, So the same is in research. I really think that it can change the way a doctor, that's my job actually. I work with young doctors that are residents a lot. If they reach a certain level, they changes their practice, their critical thinking, and then they become eager to explore themselves with curiosity. What they are doing in the clinical practice, they become better. But this doesn't arrive immediately. So my suggestion is to find something you like, because it's easier if you like it, and push through it. And you realize that at a certain point, it's not going to be tiring anymore. It's going to be actually exciting and giving you extra energy because you love it.
Have some patience in that sense.
Yeah, it doesn't arrive immediately. Yeah.
All right, that's something that we'll definitely keep in mind and apply. Last one to finish it off. Can you name one person who is either dead or alive that you still would want to have a coffee with?
That's a difficult question, because as I told you, I like to listen and to talk with people, not just to talk. So I talk a lot. But if I have to choose one, and I have many mentors I love to talk to, but if I choose one that I cannot, unfortunately, because he recently died, is Kahneman. And Kahneman was a Nobel Prize in economy, but he came from sociology. And you see the cross-fertilization. I like this. And he was such a brilliant man. He really affected also medicine because he studied the bias of the mind, how our mind works. And it affects researchers as well and clinicians as well. And I would like to know his more personal side. He did so much for the world, for the way we understand ourselves. And you only see his achievements. I would like to see the human part, the difficulties, the compromises, to understand better also, your own path. Because in your own path, now we talk about what we achieved, but daily you have to face other aspects. And I'm sure also these great minds, had to go through
The experience,
experiences similar. So I would love to know more about him. I know only about him through his books, and anyway, that's probably the person I would love to know more and talk to if I could have a coffee.
Yeah, well, great answer, and I really enjoyed our podcast together. I think the listeners will also really enjoy it when listening to this. Maybe I would say follow the movement and get in contact with you if they want to talk about it. And thanks again.
Wonderful.
For it.
Thank you so much.
Great.
This was ONtheGO, the podcast on orthoregeneration. For more content, stay tuned at my.on-foundation.org. Thanks for listening and have a great day.